to perform a major hepatectomy. Whipple resection, 62% felt that they were not adequately trained to perform that operation. Minor hepatectomy, just over 50%, and the majority of the respondents in the general surgery group felt that they were adequately trained to perform a distal pancreatectomy. So you can see that there's strong appreciation that some cases should probably be referred to regional referral centers, and that there's a lack of comfort and a feeling that they're not adequately trained to perform some of the more complex hepatobiliary surgery. So we, a few years ago, looked at liver resection in Canada, and we did this using administrative data from the Canadian Institute for Healthcare Information, and looked at liver resection across the country, excluding Quebec, from 1995 to 2004. To do this, we looked at where the patients resided, and the postal code was used to identify that, similar to your zip code, and that allowed us to identify the census division that the patient lived in. So over that 10-year study period, almost 10,000 patients had a liver resection in Canada, with an average age of 59, and 53% of them were male. The vast majority were done under an elective or urgent setting, and they had the expected burden of comorbid disease that you would see in a hepatic resection cohort. When we looked at the rates, and I'll give you some U.S. rates in a few slides, you can see that in 1995, age and sex-adjusted rates per 100,000 of population was 3.22, and that steadily rose over the period of study up to 5.86 in 2004, so almost a doubling, an 80% increase in the rates of liver resection in Canada over that time period. We wanted to see whether or not there was significant variation in the rates between the provinces, and to do that we used two metrics. The first, coefficient of variation, which is basically the standard deviation of the rates divided by the mean, and the extremal quotient, which is the ratio of the highest to the lowest rate. This is a busy slide. It shows the values across the country, and the two bottom rows show the CV and the EQ. You can see that there is significant variation. Those numbers show quite extreme changes, so significant geographic variation in the rates, which raise interesting questions about access to care, appropriateness of the procedures, and burden of disease. We also looked at the mortality rates across the country and looked at them by province, and you can see these are the rates for the whole study period for each of the provinces that we looked at, and the rates are quite reasonable. You can see at the bottom some of the provinces on the East Coast had a little bit higher than you'd expect, but the rest have quite reasonable rates. This is a graphic of Canada with all the census divisions on it, and the different colors demonstrate the different rates. Yellow is the highest category of rates, and you can see that the yellow are spread out across the southern part of the country around the big metropolitan areas in general, and that there is big differences in the rates across the country, especially as you get more geographically remote. So we wanted to compare those to the United States rates. To do that, we looked at Justin Dimmock's paper from JACS in 2004. He looked at rates in the U.S. from 1988 to 2000, and he looked at what percentage of the cases were done at high-volume centers, which he defined as greater than 10 liver resections per year. So in 1988, 37% of the liver resections were done in high-volume centers. That had increased by 2000 up to 57%. and he appreciated in his study that there was big differences in outcomes between high and low volume centers, and this audience is very familiar with that. We compared directly the years where the studies overlap, so 1995 to 2000. And during that 5-year span, the liver resection rate increased by 34% in Canada and decreased by 3% in the U.S. And you can see that in the year 2000, the rates of age and sex adjusted per 100,000 are quite different. In Canada, 5.9, and in the U.S., 3.4. So over the 10 years, nearly 10,000 liver resections performed at 247 hospitals in Canada. The proportion of the procedures that were done at high-volume centers in Canada, which we defined the same as DIMIC, was 42% in 1995, and by 2004 that number had risen to 84%, so a doubling or 100% increase in the number of liver resections that were being done at high-volume centers. So significant variation in, significant change in the rates and significant regionalization. So is Canada moving towards regionalized care? I think the answer, at least for liver surgery, is yes. And it's being done not based on any regulation or government dictates. It's really based, I think, on a number of factors. One is the finding in the survey that most general surgeons are not comfortable performing the complex hepatobiliary procedures. Two, there's an appreciation that the outcomes are probably better when sent to regional referral centers for multiple reasons. And three, I think that there's probably financial disincentive to do these cases in a low volume center. The pressure on the system and the lack of access to the operating room, these cases are not remunerated well, and when you have very limited access, it pays better to do high volume, less complex surgery. Thank you very much.
Thank you very much. It's a great pleasure to be here. I don't know why my boss told me I had to wear a coat and tie to give my presentation. My interest really is in the delivery of surgical care in rural areas. So what I'm going to do is talk a bit about the surgical supply in rural areas. I'm going to show you some new data that hasn't